One of the specific activities performed by pain psychologists is completing mental health evaluations of candidates for implantable pain devices such as spinal column stimulators and implantable pain pumps. Although there are some similarities between the mental health evaluations for these implantable pain devices and more general mental health evaluations completed by psychologists in other settings, there are also important differences between these evaluations. This presentation will focus on these latter differences, discussing the relatively unique components of implantable pain device assessments and some of the best strategies that I have found for obtaining the highest quality results from these assessments. The first component to consider with implantable pain device assessments is how to skillfully use them for identifying major psychosocial concerns. Identifying risk factors that made it less likely that a patient would benefit from an implantable pain device was originally the primary reason for carrying out implantable pain device psychological evaluations in the 1980s and 1990s. At that time, implantable pain devices were new, expensive, and they could cause a variety of serious side effects, making it wise to be highly selective about the patients receiving the devices. Although the landscape has changed greatly in the 21st century in regards to the risk associated with implantable pain devices, there remains an emphasis on selecting patients that are most likely to benefit. In the past, risk factors identified during pain psychology evaluations were often called contraindicators, and this is because they were often used to suggest that an implantable pain device was not appropriate for the patient. Because the research linking psychosocial factors to poor implantable pain device outcomes is far from perfect, however, it is more accurate to replace contraindicators with softer language such as risk factors or red flags as shown in this slide. For the pain psychologist, they can consider red flags as falling into one of three categories: behavioral, psychiatric, and psychosocial. The primary reason for categorizing these red flags separately is that they require somewhat different methods to assess. Some red flags can be effectively assessed via self-report during an interview, for example. Others are better gathered by questionnaires. And finally, still others can often be best evaluated by reviewing patterns from the patient's medical record, discussions with their medical providers, or through objective indicators such as laboratory tests. The second major component of the psychosocial evaluation for implantable pain devices is the choice of assessment measures. Even though there is reasonable agreement about the red flag areas of concern shown in the previous slide, there is much less agreement about the specific measures that are best suited to detect each of these concerns. As a result, there are usually at least several questionnaire or other measurement options available for each area of the evaluation. Logistical factors play an important role in the selection of these measures. There are, for instance, an increasing number of screening tools and short forms of questionnaires available to pain psychologists that offer good reliability and validity, and that can be used in contexts in which there is limited time for the assessment. It is also possible to substitute objective measures such as pedometer numbers, sleep tracker results, or findings from laboratory tests for areas that might in the past have been measured only by self-report or by questionnaire. And these objective alternatives might even be argued to be superior when available. One of the ways in which psychosocial evaluations for implantable pain devices has evolved over time is that they are now placing a reduced emphasis on pain reductions as the primary outcome and an increased emphasis on functional improvements. For instance, the usual test of success for an implantable pain device in the past was whether it produced a 50% or greater reduction in pain severity. Whereas now we also want to know if the implantable pain device has helped the patient to get back to work, get more exercise, or improve their emotional health, among many other possible benefits. Because of this shift in defining outcomes, the pain psychologist should now include specific patient-centered questions in their assessment that elicit functional goals from the patient for their implantable pain device. Some patients may need cueing or examples in order to generate functional goals for themselves, as many patients have for so long simply been asked about pain severity by their providers that functional questions are new to them. That said, the inability by a patient to identify personal or functional goals, even with help from the pain psychologist, could probably be seen as a red flag in itself. This slide provides a specific template for asking functional questions about implantable pain devices that can be defined in a quantitative form. The intent of this format is to be able to refer to these same goals with a patient after the implantable pain device has been placed in order to evaluate whether the patient's goals were achieved. Once the pain psychologist has completed the psychosocial evaluation with a candidate, there are several important tasks to consider. These include what written feedback to provide to the pain physician, what issues perhaps need to be discussed verbally with the pain physician or a treatment team, and finally, what feedback should be provided directly to the patient. The ideal circumstances for the pre-implantable pain device assessment is when this evaluation takes place in the context of a broader multidisciplinary environment, where the pain psychologist can directly speak if needed with the pain physician or referring physician. Even the best written report, for example, can easily be misunderstood, be too technical with psychiatric language, or be too lengthy for the physician to effectively digest, meaning that written reports with more complex implantable pain device candidates will often, if not usually, benefit from an additional face-to-face conversation with the referring physician. Because the medical risk associated with implantable pain devices are much lower than in the past, it is possible to be more liberal in supporting patients to receive pain device trials even when psychosocial concerns are present. However, in these cases, it is also valuable to consider treatment options that can tilt the odds in the favor of a successful trial as much as possible. The setting of the psychosocial evaluation is in many ways the optimal time to discuss with the patient the benefit of participating in options such as mental health therapies, pain groups, and relaxation and meditation therapies prior to trialing the pain device. These treatment discussions are optimal at the time of the psychosocial assessment because the patient is often highly motivated at this point to receive the implantable pain device, and this motivation can then carry over to helping them to participate in other treatments that may help them to be approved for the pain device or to maximize their probability of success with the pain device once received. A final recommendation for the pain psychologist is to conclude the implantable pain device assessment with some brief feedback to the patient about the nature of any concerns and recommendations that appear warranted. This can, on one hand, improve rapport between the patient and the pain psychologist, and it is also the best time for the psychologist to share their concerns and recommendations in a way that is well received by the patient. I have, for example, found it more effective to discuss a treatment referral with a patient at the conclusion of the implantable pain device assessment, where I can obtain their feedback and commitment, than by discussing the same concern or recommendation later when they've already been declined for a pain device, or perhaps they have been approved and now have their focus exclusively on getting the device. The final consideration for the pain psychologist in completing implantable pain device evaluations is to consider ways to expand this assessment from being useful only for pre-implantable pain device decision-making to becoming useful also for long-term decision-making. For example, given the increasing focus on functional changes and quality of life improvements as implantable pain device outcomes, it has become valuable to formally reevaluate the patient in the months after receiving their pain device in order to assess changes across pain severity, functional, and psychosocial dimensions. Although it is not necessary to remeasure every factor assessed in the initial psychosocial evaluation, the emphasis at the post-implant evaluations should be on areas sensitive to change or that were identified as goals by the patient or provider. The picture shown in this slide offers a model for assessing the implantable pain device candidate initially pre-device to identify major concerns and goals for the procedure, and then at shorter and longer-term post-device placement dates to evaluate the multidimensional success of the pain device. The other factor supporting post-pain device placement evaluations by the pain psychologist is that these follow-up assessments can provide opportunities for the pain psychologist to identify the presence of psychosocial problems in the patient that may benefit from additional intervention. Outcome research with implantable pain devices shows a clear pattern of decreasing success from short-term to long-term follow-up. One reason for this decline in efficacy may be that behavioral and psychosocial problems arise post-pain device implant that undermine long-term effectiveness. In order to maximize the quality of pain device outcomes long-term, it may be helpful to think of a patient receiving an implantable pain device as being part of an ongoing multidisciplinary treatment that includes the initial pain device placement as the foundation, but that also includes periodic visits with the pain psychologist in the aftermath.